Evening.
Okay. Let's do this. Just going to share my screen. And there you go. Okay. Can you see my main screen? We all good? Yes?
Yes.
No? Good.
Yes.
All right. Now, it's a quite an ordinary image you can see here. Basically, we have an image of someone smiling and they present the practice that they're not happy with their smile. So to most people, well, what's wrong with your teeth? I mean, the patient's not happy. And to us as dentists, we can see that there's some discoloration in between those teeth. And, something's also been happening here. I mean, so patient says, look, I've been under periodontist care. And I think also I've got gum disease. And then when I had my veneers trimmed, then it's cut my teeth. And I come to it later on, and you can see a lot of things here, and we'll discuss this later on a bit more. But what we'll talk about as much is we'll talk about all the questions that we need to talk about. What would you consider the patient request? What questions we ask the patient? What will be our diagnosis and the treatment plan? So we'll go this in more complexity. And when you look at this patient, what would be your first impression? Can you want to tell me what's the work has this patient done, in your opinion? Which teeth are treated?
Top 10 and bottom 10, most likely. And
okay, all right.
there are some crowns on the back teeth, but mostly if we're talking about the white part, then.
Okay, the shade's not too bad. As a matter of fact, they match the shade well. Her main concern is the posterior teeth, naturally, the molar crown here. But her concern is about the anterior 4 veneers.
Yeah.
So 1, 2, 1, 1, 2, 1, 2, 2 had been veneered. Interesting enough, this was veneered by her periodontist. So and he said, look, I can do those veneers. I've got a bit of time, so I'm happy to do them for her. I mean, irrespective of who did it, it doesn't matter. Anyone can do whatever. But the issue is that veneers were done, and now we have a problem. Okay, and there has been no movement of teeth. It's so fine, so there's a problem, and so she's very concerned about this, and that's one of the reasons the patient presented. Why do you think veneers were placed on those teeth? Isidora?
Why were veneers placed?
Yeah.
It's hard to answer without the previous. I'm guessing maybe aesthetic.
I don't have a previous one either.
Okay. I'd guess aesthetic.
Which came first, Sarkis?
I'm sorry?
What came first, the back ones or the front ones?
No, there's no back to it. The main concern is the front 4 teeth. She's concerned about the discoloration.
They also the difference in the length to the curve where she's shorter at the back and then it dips down.
Yeah, that's one of the assessments. But what do you think was there before?
Dr. Sarkis, Shine says fluorosis.
Does she have like an incisor, incisor molar hypomineralization?
It could be. It could be. That's a really good point. It could be.
They could have had gaps.
It could be.
Because of the size, it looks like there were gaps.
Gaps. Okay. All right.
Microlaterals or.
Okay. What else could be a reason? I'm building up to interesting phenomena. So in many ways, there's a reason why these teeth are veneered. Would that be correct?
Yeah. Do you want me to answer, Dr. Sarkis?
Yeah, please.
Yeah. You mentioned about the gum disease. So she had a receding gum, and the periodontist wanting to close the possible black triangles and trying to just reduce the diastemas because of the, or probably receding gum, just to have a bit of a coverage there.
Well, I agree. I agree. And there's probably a bit more. I agree with recession gums, and she must have been very concerned, so he didn't know how to do it. But you know, when periodontist does the veneers and there's a gum recession, you think they're probably a bit more than that. There's a gum recession, you would think that he would consider some sort of a coronal advancement flap, right, or CT flap, or micrograft, or allodermal graft, whatever it is. But they would have done that first before doing this, but it was restoratively corrected. So that was interesting. And she's also concerned about the cave formation here. That's a concern, isn't it? Especially when veneers been there for 2 years, as a concern here. So, you know, if you did veneers, your patient come back after 2 years, especially they come to every 4 to 6 months, that would be a concern for me, okay? So what do you think is a concern here? Anyone can tell me, please.
The gap at the front 2 teeth.
Yeah, and there's a discoloration here, see? Between 2-1 and 2-2.
Is that a tar because of the smoking or something?
Now,
So is there a
it's
marginal?
possible demineralization of the cave formation, or it's possible staining of the residual cement.
Mhm.
Or it could have been like that in the beginning, that they haven't wrapped around far enough.
Yeah, that's a possibility. But even if they're wrapped up, see, okay, now we talk about design, aren't we?
Yes.
Correct. So there was a number of issues here. Okay, is my first impression. One is the reason for veneer placement, and they make sure right, just like with gum recessions. I think also molar incisor hypomalacia syndrome, that was really good too. Thank you so much. That was excellent. Okay, design issue comes after something else. What else could have happened that they did veneers? What's okay to all the orthodontic colleagues? Okay, orthodontic general and orthodontist colleagues. What's the reason that's very common between the laterals and the centrals?
Tooth size discrepancy.
Okay, all right. I'll come down in a minute because it's interesting. Let's go to the next one. So what I'm trying to say is that in every case, would you see that this is a complex smile line? Because
Yes.
bottom and top tip are on the show, right? Lips are good, they're nice, symmetrical, I like it. And Christina, you mentioned about comes in and dips down and goes up, okay? So the problem was that, would you make this a bit more shorter in the future? Would you make this a bit longer? And how would you make this longer? Because there's a lot of issues in relation to occlusion for this patient, okay? She's also a TMD patient too, by the way, but I'm gonna remove TMD. Okay, now, we've spoken about this quite often, right? Stabilize, control phase, maintenance program. Patient understands it has to be in the maintenance program. And then we talk about diagnostic phase, reassess, and then definitely treatment and back to the maintenance. So this thing comes around here. We understand this, and it's very important that we understand the concept. So let's go back to this patient. She's a very pretty girl, about age 30. And when you look at it, well, it doesn't look too bad. When most people look at it, there's nothing wrong with those teeth, but she's not happy with it. Okay. Now, I like, without being discriminatory, I like all my female colleagues to answer this for me. Okay? Please tell me, what do you think of the aesthetics?
Looks like they were made by a periodontist.
No. Let's just be, look, any specialist can do anything in dentistry, okay? You can't comment. I'm just saying it's not a periodontist because the gum specialist should be more careful with the gums, and I accept that, okay? So let's go next stage. Ladies, Christina, let's give another opportunity to
make a better comment. That they look a little bit too long. Either the distal ones that are short, or the front ones are long. There's too much discrepancy in that curve of speed there.
Okay, that's right. Okay.
So the central incisors are very large compared to the laterals, and they're very big and square and masculine looking in a way. So it doesn't suit her face.
Right, it doesn't suit her face. And let's say if, thank you for that. Let's say if you say to her, okay, we want to reduce them a little bit, what would the patient's response be? When she wants, I mean, you know, she's happy with the length of the teeth, but what else would you do? See, it's a difficult thing, isn't it? If this was your patient, what would you do for this patient? How would you fix? In a way, what would you like to see in this patient done?
I would do a smile design, something that she can look at before the veneers go on, so that then she's less likely to be dissatisfied if she's had some input into the design in the first place. Very good, absolutely. So it's very interesting. See, when we talk about in terms of aesthetics, is it objective or subjective? Well, it's both. There are some global norms of what's aesthetic to people all over the world. There's some agreement on what's aesthetic, and there's very, very subjective ideas between dentists and patients as well. So it would be crazy to ignore that. I agree. Well said. And in terms of between dentists, do you think there's a general agreement what's aesthetic, what's not?
No.
Dr. Sarkis, we have a question. Does she need an expansion of her upper jaw? Are male dentists allowed to comment?
All right, please. Who was it by?
Just give me a minute. I'm trying to get through the chat. I think one was by, Nimish. Dr. Nimish is written.
Okay, all right, let me explain this. Just coming back to your question. One of the reasons she didn't want any type of orthodontist, the reason she had veneers is to come to you, and I come to when I do the preparation, I remove those veneers. This type of cut, okay? And this type of cut, and she tells me that she wasn't aware, wasn't informed that the dentist was going to cut teeth. The biggest problems we have in dentistry is that when dentists cut teeth without informing the patient. And this tip actually rotated once, and they were rotated, and that was one of the reasons it was decided to do veneers to close the spaces. And the design is an issue, there's a lot of issues here, and Dr. Howard mentioned that as well. Now, you can expand the arches, no question about that, but in this particular case, how much will it achieve? Because the arches is pretty well, I mean, you could expand a little bit, but there's far more to it. Now, you see, the problem with this is that she's set in the length of those centrals. You know, she does them shorter. What else can we do to help this patient? We need to ask the patient, aren't we? We need to ask the patient what does she want. She's actually so exhausted, so emotionally upset, doesn't know what she wants. So these sort of patients come into practice quite often, and they're very, lovely people, but they don't know any better. They have no idea what to expect. They're just given something without a choice. And this is where all the problems start. Miscommunication, not necessarily not treatment in any one particular way. I think a lot of the problems that arise, in my opinion, is because of miscommunication between the dentist and the patient. And again, as Anna said, if you had done like a diagnostic mock-up or any kind of a mock-up, that given the patient a conversation point, talking point to be able to restore it. Because I would other cases to show, I'm not going to show the mock up this and that, the whole procedure. We talk about in the course, in the program. But nevertheless, aesthetics is a mind game. It's a really mind game. And my problem is when patients come in this position, they're already sensitized. Okay, so it's very, from my point of view, I have to put them in a zone where they're comfortable. And for instance, what I would do in this particular case, and I'll tell you later, I'll go back in, I will put some composite mock-up, I'll even bond some composites and let the patient wait for a while, and there's a lot of other things you can do to improve it. So if you're going to go, I want you to think of the answer. If you have to improve the length, and Dr. Howard mentioned it's going like this, okay? So what would you do? Will we reduce these and make them a little small, or would you do something else? That's something for you to think about, because the patient had certain ideas of her own. But nevertheless, you got to understand, we've got a history of gum disease. we probably try and work out what the patient wants. And we try to work out how to achieve this. So what we do normally, we'll take some quick bite wings. So this is the bite wings, as you can see. At this age, you can, you see some areas of loss of attachment and pocketing. You can see, for instance, the decay under the crown. What sort of symptoms would you expect this patient to present as well, besides those dissatisfaction, those porcelain veneers? What other symptoms would you expect the patient to have?
Cold sensitivity.
Cold sensitivity, okay. Can you see also that right here, can you see that right here? That's a calculus, that's mist. See, when we talk about periodontal disease, whenever I see a calculus, I feel really good because I know when I remove it, it'll get better. Any periodontist will tell you that. So you like to see some signs that are causing a problem. There's no calculus, perfect oral hygiene, we're giving gum recessions and bone loss. Well, that's a serious problem. It needs to be addressed quickly. So in this particular case, the patient got severe sensitivity. So we got a number of issues to think about. Gum recession, sensitivity, anterior veneers, okay, poor design, marginal, discrepancy, and poor integrity. So all these things are coming together, okay? So it's very important that we sort of explain what our clinical findings are. Naturally, in being a specialist, I like to maintain a very nice balance between everybody so I can do my job, fix the problem, resolve the matter, and patients on the way. That's what I do most of the time. So it is something to consider. You never underestimate the importance of a simple periapical or a simple bite wing. It's gold. I will sit back and blow this up on a large screen, as you can see, and I will look at it in detail, and I'll have the patient here with me. We'll look at those images and we'll sit down and go through one by one to give you an idea. So let's go to the next one. Look at the periodontal charting.
Excuse me, doctor. She's missing premolar on all four.
Past orthodontic treatment, yes. Had braces before, so the answer is no. Won't have braces, but there's a line of therapy nowadays. Okay, so we'll come to that in a minute. Okay, you answered the question very well. There's a contact problem there. Okay, here and there. Okay, now as you can see, Dr. Howard mentioned there's missing premolars here, and we have a frication involvement also. So when someone presents at the age of 30 with frication involvement, both on the upper posterior and lower posterior, does it ring a bell or doesn't ring a bell?
It's a bit young for that to be happening.
Exactly. So the important thing is, in generally, simple things are missed. It's simple. It's missed. I mean, the issue is that you're going to measure, to manage you need to measure things, and it's missed, and that concerns me because when you're seeing low risk cases, and I ask a general dentist or any old colleagues, have you got a period chart? I haven't got a period chart. Well, how do I know what the problem was initially? So when you start looking at aesthetic dentistry, you're going to look at the initial presenting parameters. Okay, periodontal charting. Okay, you're going to get this mouth in health. And you're going to tell the patient, I'm not going to replace your veneers. I don't care what it is. I think a guy down the road says wants to do, 10 veneers or $6.99. It doesn't matter. Okay, I normally tell them I fix $6.99 veneers because that happens. It was cheap, got it, done, and the result is we have to redo it because not a lot of thought was exercised in designing those veneers. But that's not the issue. We're trying to help the patient. Okay, so we're going to move forward from here. So when we look at the x-rays and look at the chart, you start thinking about what? I mean, I'll just make it easier. Risk assessment.
TMD.
I'm sorry?
TMD, look, because she's got the bottoms don't have extraction. The top does. And you said she had jaw joint problems?
She had TMD pain, but it's not always related to the occlusion, Dr. Howard.
Okay.
You know, like we can, occlusion and TMD actually is part of the course here. I'll give a small lecture with Derek, I think this weekend coming up. TMD and occlusion has been sort of put together. Unfortunately, we sort of try to put together because people associate TMD with occlusion. But that's totally unrelated thing. Very rarely are related, as times are now related, but in a very small minority of cases, more about as a result of TMD and not because it's a cause, occlusion a cause of TMD. So let me look back to this picture. Assuming we assessed and analyzed all the factors for this patient, how would you treat this patient? We fix the TMD, she's comfortable. We improve the oral hygiene, which is very important. We have a recurrent, poor margin integrity on the distal, the 4-6, that's the molar. Well, how would you treat this patient? Everything's not under control. How would you treat this patient? I mean, in other words, would you make this shorter? Would you make that longer? Do you understand what I'm saying? Would you, what would be your main aim? No takers? Anyone, any good answer.
How about aligners?
Aligners, yes, you can.
Because then you'd intrude the anteriors just a little and then extrude the thing and split the difference.
But this veneers, you see, I was showing the back with the linguals on them. There's quite a long veneers. You can reduce the veneers, can't you?
Yes.
You can reduce them. So how would you reduce them that you want to show the patient reduce? How would you do it?
Digital smile design.
Well, you see, there's something very simpler than digital smile design. Is you can get a texter. You can just
okay.
on teeth. And that's your best real smile design you'll ever have. Okay, so that's one way. But there are many ways to treat this patient. Okay, many ways. And see, it's important to understand that when you look at this patient on retracted view, and I purposely want to bring this view in now, is what do you see here? I mean, you've seen the molar hypoplastic area, and if you want to answer the question, why did this happen? Does anyone know when did this happen? Which year?
When they were 6.
6?
Because it was probably on the anteriors in the first place as well.
Yeah.
Knowing that.
Well, not with below 6 probably.
2 years old.
How long? How old?
2.
2 years, 2 to 3 years. That's when it was just started calcium.
1 year, right? Riyadh said 1 year.
Could be it depends on the development stage of the patient, between 1 and 3 years. That's when it calcifies. Look at the molar classification. After a bell zone, you get started calcified. So somehow the ameloblasts were sort of disturbed. If it's this is a hypocalcification and hypoplasia, so you both have both matrix formation disturbance and also you get calcification disturbance. So that's how you classify it. Okay, so what else do you see? You're going to do statics. Imagine patient with a really high smile line. What will be a real problem that you really think about this? What do you see?
A gingiva is very upset up there in the anteriors.
Flared up.
And
Okay. All right. All right. Flared up.
and the papilla.
Yeah. Okay. Let me tell you, this is after gum therapy. It looks flared up. It's okay. It's seriously, it's okay. It's being cleaned out, and once puffiness gone, we got a bit of a recession, as you can see. Here's a marginal junction and dysplasia between the veneer and the enamel. This is the same. There's nothing here. There's something happening there. There's something happening there. It's a stain. We try to clean this area as much as we could. So we tried. We couldn't clean here, we couldn't clean there. So something needs to be looked at. But something important that I want to have a look. What else is concerning me when I look at this case?
They're 2 years old, you said.
Yeah, but something else. Look very carefully.
Is the length in a canine and premolar that pretty much, of course, the front ones are already we talking about, it seems longer. But now when we do the aesthetic design, I'm thinking if you see the incisal platform at 1121, and if you see 13 and 14, then even 12, I think we still need to increase a bit of length. And if there is a high smile line, then we are in a bit of trouble there. But if the lip is covering, are we talking about the smile line here? The discrepancy and asymmetry between the left side and the right side?
No, all right, you can have a smile line, but something that's critical, that's going to destroy no matter what you do. And the patient has to be informed.
Dr. Sarkis, Tina says canine gum line much higher.
Okay, the canine gum line is higher here, similar to that one. She's thinking, what else? You're thinking, please, very good, keep going. Very good, keep going. So, see, the thing is that everyone is just totally obsessed with the white aesthetics. But you
Gum
forget
aesthetics, yeah.
pink aesthetics. So what am I looking at? I want you to get pink aesthetics. It sticks out like a dog's balls. You're going to see it.
Blunted papilla on the,
Oh, finally.
Yes.
Can you all see it now? It's there looking at you.
like dog's balls.
Of course. It's right there.
Hmm.
Yes, you mentioned this. What happened here? Okay. What's the problem? Why is it this way?
The cement was left.
Let's say it's not. What's the problem?
So the design of the veneers, the contact area is too gingival, the veneers are too bulky, there's no space for the papilla.
Okay. The veneer stops here. Right? That's a line. This is a tooth. I'm with you all the way. Don't misunderstand me, but I'm trying to direct you all, okay? But you see, the problem is that even the periodontist knew that we got an issue here, but something happened. What's the reason we have this problem? Look at the difference from here. Look, here we got a nice papilla sharp. We got sharp, 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 almost sharp, sharp, sharp. You cross the line here, it's blunt. Why is it blunt?
So
It's
there's
not-
no underlying, sorry to interrupt.
Go ahead. Go ahead, Jane.
So there's no supporting bone underneath, I suspect. If that papilla is so much shorter than the rest, we haven't got a PA of that, but that would be my suspicion.
Okay, I've got a charting for you. Let me have a look. Yeah. Here's a charting for you. It is between 3 to 3, 3, 3, 3. So that's 3 millimeters within normal range. So I always give you enough.
It's a gap.
Huh?
There's a gap between the so it could be food impaction or she flosses and it goes zoom right up to the top.
Dr. Sarkis Khan, Dr. Khan Ravi says bone loss.
You're onto the bone loss. You see, that's why I love this picture. Okay, let me redirect you. Okay, let me redirect you. How do you develop papilla? So those of you who've done some orthodontic training, you should know how to create papilla orthodontically.
Would it be the way the tooth is sitting, like the angulation of the tooth?
I want a bit more than that.
The in and out of the so maybe the lateral was more in standing.
Now, I want you to give it, you gotta give it the right word, you know? It's like, you know, there's no tango, right? I mean, I want the right word.
So is one of those teeth rotated?
Right, rotated.
Rotated.
It's a contact problem. It's not a papilla problem. You get it? This is a contact issue. Lateral is rotated labially, mesiolabially. That was the reason I did the veneers. Am I making sense?
Yeah, yeah.
Yes.
Anyone disagrees? I'll agree. You can disagree. I don't mind.
All agreed.
All agree. You see what I'm saying? The course, the program RCODP is making you think. The rest of the literal like the mechanistic part of it, we can teach the monkey how to do it. But diagnosing the problem before you start, this is what the importance is of the diploma program, where we don't talk about technique based, but actually using diagnosis and how we treat it. So when we design these patients, before we design these patients, what would you say to the patient, knowing what I've just told you?
Can we do aligners first?
Exactly. We can close this gap, okay, in a better way if you rotate 1, 2, okay, and 1, 1, okay. It's a very common. And she says, no, is there another way? Fine. What saves the day? When you have to replace it, what will save the day for you? I'm simply talking to the patient, but I'm thinking exactly how I'm going to fix this problem already, right? So what saves the day? Isadora. Don't try to sneak out, by the way. No? I'm getting
Can-
hot. What says the
I was
day?
about to quote, what the eye cannot see, the mind cannot recognize.
That's right.
IPR. Dr. Sarkis, Dr. Sarkis is gone.
I'm listening. I'm listening. What
Dr. Sarkis, somebody's commented IPR, interproximal reduction.
are you going to achieve by that?
Oh, God.
You're aligning? Yes, you can. You can rotate the tooth. Okay, you can make provisions for that. But what saves the day is what? This is a full smile. I'm trying to tell you. What saves the day? Here's a hint. It's a full smile. What saves the day?
Low smile line.
Low smile line. Right. Okay, now we move forward. Okay, we'll move forward. The problem is, that's good because the contact pattern is held by canine. This is rotated, so is that one. So we have a problem. Okay. So what would you expect when we remove these veneers?
Crooked teeth.
Well, I'll tell you an interesting thing. I would expect decay between those two. I would expect decay on the other side as well. And probably not as much as here. But let's just go on the next slide. So we've removed existing veneers. We clean the preparations. Here's the preparation that was done by the previous colleague of a really good teeth. Now these teeth are condemned for life. There's still decay needs to be cleaned out here. Okay. Now we remove the decay here, but this needs to be cleaned out. Okay, you remove any cement that's here to allow pupillar reformation. Okay, we measured what would be important thing in measuring. If you probably heard tunnels, think people go measure up. You've got that bone here, it'll regenerate. You got to measure up. We already did measuring up. I already to measure up. Okay, but here's the removal of that. Now, just to give you an idea, the idea was because you like the length of the TVD diagnostic mock-up, the decision was made to lengthen the posterior teeth and drop the maxillary occlusal plane down, open the bite, restore the vertical space, improve the vertical dimension of the face. And so we improved a lot of other parameters for this patient. That was the, probably considered discussion in diagnostics. But I don't want to go into that because that's, full program and discuss this case. But nevertheless, I have improved, was previously mentioned that, the extension to allow the extension of the margin into this area. And this is the decay formation we have. And there's another one here, as you can see. So that more or less this is my preparation of the canines. You can hardly see any preparations. And we teach our students how to do this type of preparations. Because we can do the same type of preparation without any intervention, really, minimal intervention, just simple polishing. There's ways to do this. And with my technician, with technicians, both Alex and Harry. Is Alex on the, Alex here? Are you here? Is Alex here, my technician? I'm not quite sure. Okay, so in a real sense, that these preparations are at equidigital margins. They're done on the microscope, you can't see them. And then we do special tissue retraction. I don't use cords at all. There's a way to do this. And the way I see it is once this is removed, it's all clean out, we're ready to take impressions. So you're going to drop the maxillary plane way down as per diagnostics. Okay. Now, the problem is that you need to make a temporary veneers for this patient. And when we make temporary veneers, you can see the problem with temporary veneers is that there's a residual cement here. Can you see that? Yes, no? Can you see that? Okay, there's residual cement here. So one of the problems we have that affects the veneer sitting is when you make your temporaries, you're going to remove all that cement. I mean, I hate making temporary veneers because of this problem. Okay, I despise the concept of temporary veneers, and I talk to patients out of it. And there's a way to talk them out of it if you can. You can just do minimal supragingival margins, but you want all that aesthetic perfection. It is difficult. Okay, but nevertheless, in this particular case, this is the rule. Does anyone know how to remove this cement? We can scale this out using scaler. Do you know how to remove this residual cement? Anybody can tell me? Would you drill it out?
Scaler.
Scaler? Well, scaler for this one. Scaler for this one here. Okay. Okay, what about here? What about here? See, I would be happy having that on. Or they can get away with it because you have, but I prefer to, does anyone know how to remove this? This is probably the answer.
Alexander has answered pumice.
Pumice?
Yeah, pumice, pumice.
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 Is that Indian dialect pumice, is it? No. Sorry. Pumice may not remove this. Something else I would use.
A fluted burr.
Rondoflex sandblaster.
Sandblaster.
Sandblaster. Serene W has answered sandblaster.
Very good. And you point the sandblaster down, not towards the gums, but down. Okay. I can easily sandblast this out. How would you know if you removed all the resin cement?
You do it with a fluted burr.
But how would you know if you removed all the resin cement?
Edge.
Who said that?
Easy.
Very good, easy. Move forward. So we talked about this, and these are resins, we have to remove them. Okay, and remove them by using sandblasting. Okay, very good. So that tells you, I'll come to this patient how we finish this case in a minute. But the importance of the restorative design and prior diagnostic is really critical to doing good aesthetics, because you have to be very highly precise at the tooth level, yet be highly precise at the smile level, and how do we integrate that smile into the face. That's the next dimension I'll talk about towards the end of the lecture. Let's do this patient. Patient comes in. Now this is very interesting. Has some veneers done, and it's around the corner. She's complaining about didn't like the shade, didn't like the color, took 6 months to make. The problem, again, you see, when I'm thinking of this, I mean, this is really interesting. I'm looking at this case here. I mean, this is not normal. And, and this is not normal. So there's a gaps here. It's just severely sensitive. So when you place a veneer, what could cause severe sensitivity? Can anyone tell me?
Exposed dentine.
Exposed dentine. Okay, very true. Exposed dentine. It took 6 months on, off, on, off, on, off, on, off. To
That would do it.
that's the history. It took 6 months on, off, on, off. He wasn't happy. She wasn't happy. They went on and on. Finally, this is on. And it's one end to the other. And it's a problem because patients there, and I see people from all walks of life, and I don't make a judgment. You can see there's a problem now with the 1-1 crown, isn't it? Correct. Any other things you see there? Anything else you see?
Dr. Sarkis, Alexander says marginal discrepancy.
Absolutely, absolutely. What else do you see here that's a concern for the patient? I mean, it's just
They're square.
Square, right? Square.
And so there's no way in the world that the natural tooth, so it can't be fitting.
Exactly. Well, see, I sort of there's also a problem here, isn't there? So something tells you there's a problem here in the first place. The funny thing is that about 70% into the treatment, the patient and the dentist decide they're going to stop. You're going to fix it restoratively. They're using a liner, it's going on and on and on and on. Nothing was happening. They got frustrated and they just took it off and then decided to go for the veneers. Interesting. See, sometimes when you plan, it doesn't work. You just want to shortcut. You just want to you've had it. You just can't take it anymore. You just want to get rid of it. And that's another story. Yeah, well, that's what happens sometimes. We all go through this. Have you got a problem here? You can see there's a redness here. Isadora, you're very good at that. Can you see this?
Cement.
Yes, it's not right.
Yes.
So when you take a good image, you blow it up, you can see it. Something's not quite right. Okay. So we got margin discrepancy. Whoever said it was right. The redness was correct. Squareness was correct. Everyone's correct. Okay, everyone's correct. So I go back, and the first thing I do, I get my 1mm tip, just to save everybody an embarrassment, and I go look for margins. Because if there's a catchy margin, 1mm tip, well, we have a problem. Usually a little less than that. I mean, I couldn't find margins, but I would be very upset if. So either two things have happened. What do you think has happened for this patient? Especially, don't worry about, there's a catchy margin. So 2 free and 1 free, what do you think has happened?
It hasn't been fully seated vertically.
Has it been seated, did you say, Dr. Howard?
Yes, hasn't been seated vertically. So it hasn't gone up far enough.
Far enough. Is it possible that it was seated, but something happened?
D-bond, bruxism,
The
the canines.
You see, what would be a common mistake during seating procedure for this to occur?
You'd have to bite down and it lift off.
If it's biting down, it's not going to lift it that way. It's coming out buccally, right?
So they pushed it at the incisal, but it's come out on the.
What was the reason for that? Dimesh? Anybody?
Maybe too.
Are you talking about the prep part or the
No,
cementing?
why? Because this gap formation.
Dr. Sarkis, we have a few answers. Alexander says contact point interference. Rupali
Contact point,
says not cemented correctly.
Okay. Well, not cemented correctly, we know that. How does contact point interference cause?
If it's too tight.
Too tight? How do you
Could
get
it be the sequence as well, Sarkis? The way the sequence that they put it in?
There's the veneers thick, or you're saying it's
The sequence that they place the veneers
right.
in.
The sequence that they're placed. You see, there's a number of problems that occurs during veneer placement, and one of them is a sequence. The other one is a contact point, and the way to do them is very tricky. So load in place one at a time. If your veneers are good fitting and you file between, go next one, it's quite a tedious process. You can put the little plumber's tape, like a Teflon tape. But to me, that doesn't make it. The issue is that the sitting process was totally incorrect, okay? And that's the problem happened in this particular patient. What could have caused the sensitivity? Assuming there is some cement on top there, what could cause the sensitivity then in this case? Like constant pain.
Exposed dentine.
No. Anybody else? That's the first part, Dr. Howard. We have a constant pain. Exposed dentine can cause constant pain. I must apologize. Yes, it can. But there's a reason why it does. Why do you have a constant pain? Patient's not clenching, they're not bruxing, okay? So that's not the issue. Think about it. I'll come to the answer later on. Yeah, I'll come to the answer later on. Think about it, please.
It's not the over drying during the cementation, is it?
Say it again, Nimesh, sorry.
Is it the over drying, and if the cementum is exposed and they just cemented it, too much of over drying?
Too much of, I didn't hear you. Say it again, please. Too much of
over drying while they're cementing, because if there's over prep or something.
no drying.
No?
Because when you have your prime and all that, that compensates for that. When you do,
Dr. Sarkis, Wade says flexion at neck on biting, moisture contamination during bonding.
at the neck, nurse put her finger to stabilize it while.
Yeah, okay. And
Would you, Ved, it's an interesting one. Would you let your nurse put a finger while stabilizing, while you're curing it? I would. I mean, if the nurse had put the finger to stabilize it, she's from a different side to stabilize it, it'll probably make it worse. I wouldn't let my nurse, but I understand your point, but I wouldn't let my nurse. Flexion of the neck, yes. On biting, yes. But what is a cause of sensitivity? You're getting there. All of you are very close. But what is the cause of sensitivity? Have you ever had a patient who when you place class 1 composite and came up with severe pain?
Etch not completely removed.
No, if you place class 1 composite right in the center of the molar, they come back. It's a small cavity. It is a lot of pain. What do you think happened there?
Dr. Sarkis, we have a few answers. Alexander says C factor.
Right.
Peary says air bubble. Sequence of curing, shrinkage, DEJ exposed. There are multiple answers. Margin is at DEJ, dental enamel junction.
Okay. All the answers are pointing to something very, very important. Is the bond that's bonding the veneer to the enamel or in some exposed dentine that's there is under severe stress. Okay. And the dentine, the bond hasn't relaxed. In other words, there's a constant tension in that area because there's a void in the whole cement layer. Okay, that every time patient bites or moves, there's some sort of hydrodynamic fluid movement that causes this constant pain. Okay, and this is so common in incorrect veneer cementation. So common. If it's a fully on enamel, although it's incorrect, you don't get that. But there's a dentine there, and the patient's got some perio and other issues. I didn't show this patient's chart. They definitely have this problem. Okay, thank you for all the images. It's fantastic, very, very good. I'm happy with all of it. All right, now for this patient, just for this patient, I decided to remove the crown because I expected something to happen on tooth number 11. I don't like what I see. Something's fishy here. So therefore, we go back. So when you get those patients in your rooms do not just say or promise anything to the patient. Just say to the patient, look, the only way I can try is to take out the crown and just have a look. So we cut this, you know, it's a, I'm not sure it's an IMAX one. We just cut this crown and you document. Every time you do something, you document. So I remove the crown under a microscope and it's bonded, you know, to the tooth. You can see the composites. Someone tells you there's a rotation here. Someone tells you there's a rotation there. And I'm not sure what you see, but something tells you that there's something happening here. And something looks like that doesn't belong to the tooth. Okay. So when I talk to you about placing subgingival margins on crowns, I mean, naturally, I'm sure it's a very conscientious dentist, but this margin of excessive cement, we just cannot afford not to see, because that's going to cause a lot of problems. Now, if you tell the colleague that, look, there's a lot of cement you left behind, so you're going to be kidding me. You never left the cement behind. I can show on the X-rays. So document your cases. Okay. Not only document your cases, you can see the rotation of this one compared to that one. You can see the loss of papilla from the lingual areas, from palatal areas. You can see the excessive cement here. Okay. You know, I don't have an excessive cement. Yes, you do. No, I didn't. Yes, you did. Okay. So, you know, what residual cement? It's here. Every time I replace veneers, I find a lot of residual cement. It's always left behind. You gotta take time to clean this residual cement when you place veneers or crowns. So this is an anterior crown. That's what we're not talking about lectures. When you're doing subgingival preparations deep down, there's no way you're gonna remove the subgingival cement. It's too hard. In this way, it's possible, but I mean, you know, in the deeper preparations, you just can't. You know what's happening there. I don't have a metal ceramic crowns, and I get as great, if not better, stage than any of the ceramic abutments, especially for the older populations that require replacement of the old DMKs. So when we talk about this, and this picture says it all, and not only the residual cement here, but there's also cement all around it. Can you see what I'm talking about? Can you all see it? Yes or no?
Excuse me.
Mm-hmm.
Wasn't it over contoured what before? So how much is cement, and so how much was
This is
the porcelain being?
No, this is cement, Dr. Howe. This is cement.
Yeah.
This is a yellow color. That's not the crown.
Yeah. But wasn't the crown too wide anyway?
It was.
Wasn't
The problem is that crown never actually touched the tooth, the margins. Stay outside and resin fill the gap.
Okay, so it's the technician as well, not making a
No,
good
I
fit.
wouldn't blame a technician.
Okay.
I will never blame a technician. Whoever puts his crown in the mouth is responsible for that crown. You're not happy? Remove it. Get it back. No technician's fault. Once that crown's in the mouth, it's your problem.
And cemented, it's your problem, yes.
It's your problem. It's definitely something. It's definitely something. They never bother to clean those. I'm telling you, they never
But
bother.
could you?
Mm-hmm.
But could you, with a crown that was that wide at the gingiva,
Mm-hmm.
because it wasn't a normal. That's a normal shaped tooth, where the crown was so much wider at the gingival.
Mm-hmm. Well, look, I agree. And again, I haven't got a photo of the temporaries, what they were like, no idea. But I'm showing the problem, you know, the problem. And this is a serious problem. So when I come back in terms of these procedures, the idea is to remove these cements, okay? And so we have a problem here because, see, whenever you have teeth that are in a correct symphony with one another and you've done your aligners, it's so simple to prepare them. They're so easy to prepare without intervention. Look at those. That's my preps, perfect enamel. That requires non-local. Okay, we have a problem here because previously I think it was suggested the not extending the veneers all the way down. I want to extend my veneer to the enamel margin there. So it's going to be quite deep. So quite deep. You see, so the veneer will have an elbow. Okay, you know, it's an elbow. The veneer will have an elbow. That makes sense to actually go in there, both sides. And you know, whether you like it or not, it's a necessity in this case. You know, I wouldn't want to build it legally, palatally by composite. I would rather have a porcelain abutting, you know, the actual enamel margin. So in many ways, you know, what do you see a problem in terms of sticking those veneers in this particular area? This is about a millimeter and a half. What do you see a problem when we try to fit this in there? Anyone? Yes, no?
The pillar's missing.
What's missing, Dad?
The papilla.
No, it's more,
Between.
this is more mechanical now. See, I've gone.
Oh, okay.
All right, I've gone for papilla. Now we're going to look at tooth.
Dr.
Is it
Sarkis, minimum thickness issue.
of what? Of minimum pair of minimum thickness of
the veneer.
Of the veneer.
Yeah.
How thin do you think this veneer is? Or how thick is it? This veneer here is about 0.5 millimeter. So is that one. So we're going to fit that in, right? We're going to go back in, try to fit this veneer, correct? Is it sitting?
No.
Whose problem is it? Is it technician's problem? Should we blame that?
The impression in the first place.
Impression. Who says it's impression?
Me, that was Christina.
Or anybody else? We got a few people in the audience. Who says it's impression? Come on, vote. I want voting.
So it could also be a contact problem, and it's going to have residual cement again, like the original one had. Possibly.
Yes. Jane, that's a good point. So how would you fix it?
It is.
How would you fix this?
So it needs the elbows, so the margin goes right through to the linguals, so that way you can see the margin.
It's got the elbow.
Yeah.
It's got the elbow, right? But it's not sitting. How would you fix it?
Dr. Sarkis, Alexander replies, it's the prep that has an undercut.
Prep is an undercut.
Yep.
Okay. Is Alex here, my technician? Alex, Harry, are they here? No? They're supposed to be. Okay. So prep's to an undercut. Let's go back to the prep.
So could it be also a path of insertion issue? Like some of them insert from the labial, but some need to insert from the incisal or a different
Absolutely. This
direction.
is going for the incisal. This is going for the incisal labial. It's going actually 45-degree into it. So how would you fix this problem? It's going to go up there, right? There's a gap here. I'm going to give you here. There's a gap there, right? There's still a gap there. I mean, it's not sitting. How would you fix the problem?
Some articulating paper between the teeth, find the contact, and it reduced.
That's right. You just keep adjusting. We go for the program. Okay, assuming you got this one in, let's assume, but there's another problem. The next one. The next one. That's not sitting either. I'm trying to make them see. What I'm saying is that when you get those veneers, the propensity is that everyone has to put them in cement and see you later. You can't wait just to stick them in and get the hell out of there. 5 minutes, all done. That's all the mistakes happen. I'm telling you because I know it. I've done it before. So that was not sitting. So I ring the lab. I said, guys, what's going on? You know, like, you know, gave you a really good impression.
Were you drunk?
You know, what's this? I'm not happy with it. Okay, is it dentist's fault? Lab's fault? What would you do? None of them are sitting. 1, 2, 3, 4. Alex, You gotta answer this. These 4 veneers are not sitting. What's the problem?
Wrong patient. I've done that before. I can tell you I've done that.
You know that joke, don't you? Someone goes to hospital and says, we got some, if his leg removed, he says, we got some good news and bad news. He says, what's the bad news? He said, we removed the wrong leg. The good news is the guy next to him wants to buy slippers. Tight contact.
Tight contact, yeah.
Contact. Okay, so.
And it's also too
So how
lingual,
would you
the
fix
too
the tight
too
contact?
gingival.
Yeah, I know. But how
It's
would you
too
fix the tight
gingival.
contact? Can you see
What
it
you do?
here, articulating paper here? So you put them in and you adjust them and make sure you fix them, okay? Let's keep moving forward. And you can see, same problem, okay? See the rotations cause so much problems. And, you know, and again,
There's a
you're
gap at the
hoping there's contact problem here, but actually I took that image on purpose because it's not
it's
sitting.
missing.
That's right, it's missing.
Is it rotated?
So that's the problem. Well, it's this not sitting. You see, if this sits, it'll come around, and this will come around. Do you get the point?
Yep.
Sarkis,
Yes.
what about minor tooth movement in the temporary stage between impressions
yes,
and
it's
cementing?
possible. It's possible. How would you fix that? Good point, William. It's coming up. I like you coming right,
Yeah.
like, you know.
Yeah, always do.
Yeah, go on.
Yeah, it'll mean a bit of adjustment, interproximal contact adjustment, because you're not going to take another set of impressions and start again. Yeah, it's going to take a while, because in the temporary stage, with patients and I assume they had temporaries, there can be minor movements quite often that happen, especially with multiple preps like that.
Absolutely. How would you fix the problem?
I'd get my associate to cement it, or there's going to be a bit of, it's going to be adjustments like we were talking about with contact paper. I'm talking about minor adjustments, or it's not easy. It's just not easy. You know, it's going to be fiddly.
Okay, I'm going to ask you to think about this, because we can cover this later on, but we did fix the problem. Okay, we did fix the problem.
Yeah.
Let's keep moving forward. That's such a, but I want you to think
Okay.
about this. So finally, that's a perfect fit now. So it's all sitting nicely. And then, you know, here's the veneers. You can see there's the contact points all perfect on the model. And, you know, that's before, and that's your veneers all sitting nicely. That's the color you prefer, which is fine with me. You know, so that's before, and that's after. We bleach the lower teeth. I'm just going to quickly show that's before and that's after. Same patient, all the contacts have been fixed up. And that's before and that's after. The lip face contour, you can see that's because we better lip support overall, improving vertical dimension of the patient. You see that when you improve some of the facial profile, there's an increase in the column of the nose. You talk about dental facial aesthetics, how we put the whole thing together. We talk about this in the program. Those who are doing the program will learn how to do this, okay? But I'm telling you the possibilities. And again, smile and smile, continue to change. That gum now doesn't look too bad after all, does it? Yes? No? Can you see that? Doesn't look too bad after all, okay? And both angles, you know, gonna look good. Lip face, improvement. There's no lip injections here, just improving the maxillary profile. And again, before and after the same patient. Question?
Excuse me, Dr.
Yes?
Dr. Sarkis. It looks like the 1312 have got the wrong axial which is why the gap was there. See how they're rotated distally? They're angled distally.
I think the angle distally.
And because what you've changed is you've changed the angle of 1, 2 and 1, 3.
Of course, we're going to change. Of course, I will
yeah.
change. Yeah, of course, I will.
Yeah, and that's why they look great.
Yeah.
Because the other ones were distally low, angled.
We can talk for days on this, and I agree with you. Okay, but there's far more. We actually have improved the whole facial height. Again, the same.
Yes, yes.
Once you create special room, you can change all the angulation. All the angulation. I'm just coming back here. And again,
So much better.
Yeah. And you can see that if a bit more petite and she's more happy. So we've improved the overall, dental facial aesthetics, dental labial, and you got all facial aesthetics. She's in harmony with the case. And, this is part of the program we go through, explain how to achieve this. And the technician can't achieve this without me dictating the end point in position of the smile line. Okay, same concept, no different. Patient presenting with some work done. Look at her facial profile. I'm always grateful to my patient to give me permission to show these cases. Okay, and that means something for them. They've been through this. Okay, beautiful lady. What can you see? Over closed, mandible forward. So that's how she is smiling. Okay, and when you think about it, what do we do to the inside, providing the scaffolding that goes from here to there? There's no augmentation of lip fillers, any of that crap. The answer is, none of those. This is purely putting the arches and the teeth in the right position. She looks 10 years younger. This is the milestone in dentistry that is we call it. We can do this to our patients. Okay, and coming back. I mean, you can see here. Look at the improvement whole nose. Look at the nose goes up. Look at the whole face. I mean, she's a beautiful woman. Now, when we talk about the diploma, people say, I want to do that one, or I want to do this one, or that one. You can't. You do the whole thing. You want to learn something and properly, systematically have a correct knowledge. That's what the diploma does. We teach you how to think, how to put it together. Okay, you learn the techniques when you understand the end point. When you understand the end point, techniques is a no-brainer. Okay. It's important to understand that you need to understand the whole thing. That's what we teach on this. I'll answer more questions later on in the college. It's actually filling up. Natasha will tell you later on when we start. We actually got the date all organized. We'll send that to you soon. Coming back to the same patient. So when we talk about module 7, minimum facial and alpha porcelain veneers, no prep veneers, we add, module 11 on dental facial aesthetics. It equals dental facial rejuvenation. And that's what happens when we put things together. But by the time you get to module 7, you learn about the facial aesthetics, you learn about dental aesthetics, you learn how to integrate all.
Mine? Oh, it's just a bit much. Can you just take it off?
Okay, so coming back, same patient that we just saw earlier, maybe. Okay, you can see I can talk about many things here.
I can't go down and pick it up.
That we can easily, once you control the perio, okay, she didn't want orthodontic treatment, it's protracted treatment. I'll send it to another orthodontic colleague, and they just went on and on. She said, enough. I just want to fix. I had some veneers break. I had some implants here. I don't care if you do a slight adjustment, please. But without touching it, there's a noise out there. Okay. So, Dr. Howard. Okay. All right. So that's a veneer placed. Okay. How do we place those veneers in the right format? It's not just tooth up, it's how you place it in the arch. That changed the whole procedure, the whole dental facial aesthetics. Having said that, correct positioning of the tooth in a correct position of the arch within the facial frame will determine your aesthetics. So therefore, before, what do you see here? Okay, it's beautiful eyes, nice face, the lip is angled. Okay, all right. I wouldn't say she's over closed, but we can open up a little bit. But on the other diagram, you can see it's over closed. So you go from here to there. What have we achieved? Improvement into the lip outline. Okay, the whole composure. Okay, totally different person. All right, totally different person. Different person altogether. What dentistry does, how it does. Now, I wasn't a technician doing it. I dictated the position of the teeth in the arch. You can't do this with that digital smile design. I don't care who's here to argue with me. You have to use a direct diagnostic mock-up. We teach you how to do that. Okay, it's a lost art. People are trying to tell you, it's like a joke, right? It's like, let me explain, it's like a joke. I have to tell you this. There's a crocodile swimming into the jetty, and there's a rabbit on the jetty who's got a banana peel, puts a banana peel in the water and takes it out. The crocodile says, what are you doing? She says, none of your business. If you give me $5, I'll tell you. Oh, come on, please tell me, please tell me. Eventually, look, can't you see this banana peel here? I'm going to put it in the water and I'm going to take it out. She says, I could have told you that. He says, well, whether you tell me or not, I'm making $100 a day. That's what it is. So if you learn the art of diagnostic mock-up, you will learn to treat all your cases. We teach you in the college. Next one. Before. Okay. Profile. After. Same patient, the profile. Okay. We've changed. Okay. We've changed. It's all about the person, the persona. Dentistry has a lot to offer. Okay. We went from quite a concerning that was for the patient into a very aesthetic outcome. And again, this is diagnostic mock-up. See, that's before. This is diagnostic mock-up, and that's after. So it all depends where you position in 3D and in real time. In 3D and real time, you test the system. Digital design doesn't test the system. It's another 3-4 steps before you test the system. And it doesn't make sense to me because I can do this in an hour. If we teach you how to do this in an hour. So real smile design. Before, pay attention to the angle, nasolabial angle. Look at it over closed, okay? All right. After, reduction nasolabial fold, improvement in the column of the nose position, improvement in the lower facial. It makes the difference. This is dental aesthetics. It's not putting some slappy porcelain or composite veneer on teeth saying, hey, that's aesthetics. It's not. Aesthetics is about the whole face. How you design this, how you learn and have the end in mind is what we teach at the college. And this is a unique program that only for discerning dentists who really think they want to be to the next level, not to become monkeys and copy other people's techniques, but actually learn to think on your feet and make the best decisions for your patients. That's what we teach in the college. Is our patient. She's happy to pose. Okay. I mean, look at, we change people. Let them smile. It's the same patient. See, it's all about the steps you take to diagnose, to ask the right questions, to hold your patients in that special journey that takes them from here to there. And that's a result of your patient. It's no different. So you can apply these techniques on many patients by learning to diagnose and assess and what questions to ask. Not become like a robot, but think, because every patient is a prototype, case by case assessment. I can't give you a recipe. I'm going to make you think. Even this particular patient, how do you go from here without injections, with minimal intervention? There's all composites here. Today, how to create that look for a patient. Okay, we do this day in and day out. Very, very particular procedure. See, when people give you the opportunity to fix their teeth, you got to create that magic that belongs to that patient. Not to take some teeth from a library and try to put them in. It doesn't make sense to me. The smile and dentofacial aesthetics is unique to each and individual patient. You can't put a QR code and stick it in their face and say, hey, I've scanned you. Doesn't work that way. When we look back, and you have this very elegant patient who's presenting your practice. And you ask yourself the question, this is the last few slides. Where do I start this case? The risk for the treatment outcome. Have to think. And there's no recipes. So when I first talked about the first patient, okay, and they rushed into restorative correction of an orthodontic problem and also a smile, you can see the ramifications. So if I had gone ahead with this patient, for instance, and I prepared those teeth, I could have made a really look veneers, the upper arch, but what about the lower arch? It's a complex smile line. Look how complex it is. The whole arch is on the show. Not only that, she's a very well presented in both in her personal life. And she's a wonderful human being. And I said, look, I need permission to show you a case. She said, well, show my case if you were my brother. I said, fine. And that's exactly what I'm doing. So when we look back, I mean, she's got perfectly healthy teeth. This comes from dentist family, okay? And you can see the crowding, first molar extraction, but all the other, first premolar extraction, but all the other molars are there. So all she wants is to have improvement in her appearance. And she's realized that her case is complex. Can't be solved just by simple veneers. She went through different opinions. And when I got the letter from different dentists, what they thought, it was surprising to me that it would have been a disaster by the time I saw this patient. I explained the patient, and the patient was referred to me by another medical colleague who said, Sarkis, you mind looking at this patient? And it's quite a good referral in terms of treating with complex aesthetics. I also get complex aesthetic referrals from other dental colleagues, including other prosthodontists, because some cases are complex. And in this case, what my concern is, risk for a treatment outcome. Who understands this statement, risks for treatment outcome? Can someone explain what that means? No one? William.
Pulpitis, a dental hypersensitivity, certain aesthetics that, from your discussion with the patient, what she wants to achieve as well, what she wants aesthetically versus what you think she needs professionally as well. And also obviously ensuring that she's diagnosed properly at the beginning with no TMJ issues or bruxism issues and such. It's complex, as complex as you want to go into it.
Okay, let's assume that she's none of those, got few erosions, there's the issues, and presents in your practice. Just from your general answer, it's a tough question to ask, William. How would you look at treating this patient? What would you do?
Firstly, I'd obviously, if you once you've examined everything, films,
all that. You're dealing with aesthetics,
Yeah, I'd firstly want to know what she wants to would like to see in a smile, and with respect to those decisions, and also looking at some general photographs, look at obviously a mock-up and placing a mock-up in the mouth to see if her vision is what you want to also provide.
I'm listening. I'm just getting water. Yep, I'm listening. Go ahead.
Yep. And but the risks are always, if they're not biological, they're in communications for treatment outcome. If you don't provide what the patient has an insight, in as well, if you're not congruent with her desires, then you're on the path to failure.
Let's argue for the sake you're a good communicator. What would you do in this particular case? I mean, how would you start this treatment? Just anything. Just start with something.
Yeah, just
no answer is wrong answer. Okay, I just want to know. Anyone, please, by all means.
Yeah, what she would like to achieve.
Well, let's say she's 55 plus. Okay. I mean, let's look at her lifespan. I mean, what do you think someone at the age, let's say 55, is going to be willing to have to fix her teeth? She looks young. 55. I'm just trying to tell you. She looks young. She looks like 40. I can tell you. Go on.
Yeah, first to start with quick ortho, get the angles right for the top teeth, and then of course going with the mock-up and of course finally veneers.
Mhm.
So I would do a quick ortho to change the talk.
Let's say she comes from family orthodontist and says, "Oh no, I'm not having those braces again." You know, when she had braces, they were all bands on every tooth. You know, it's the thought of that just goes, it drives her crazy.
Well, if it's no aligners or no braces, then of course direct mock-up and try to see what we can help her with.
Marcus, would you open up the bite to get a bit more overjet?
You have to open the bite. You have to open the bite. Let me throw another thing. Let's say she got a speech problem. She hasn't got it, but let's say she has. See how complicated this case gets? Okay. And if you have to do orthodontic treatment, upper and lower, how do you find when you have edge to edge almost of the lower anteriors against the upper anteriors against the lower anteriors, you got rotated laterals? How complex would that be to fix? And how long will it take if you're doing orthodontics? So what I'm trying to say is, you get everything right, Perio's good, care's good, everything's right, perfect, perfect, perfect. Okay, now you're gonna fix this case. Is it a complex smile line? Is it a simple smile line? You know, what do you see? Isidoro.
Look, I think in an ideal world, you would do ortho, but realistically, at her age, it's probably not going to happen. She's not going to be convinced for 2 or 3 years of ortho.
I'm also,
Well,
I'm going to throw things at you so you start make you think, how would you convince her?
Well, you would say to her that the alternative is to damage the teeth. So we can either move your teeth into the right position, no damage, or we have to cut into your teeth.
Okay, let me ask you a question. How would you do veneers on lower arch? You know, let's say you open the bite, all the things, I can do it. How would you do it? And let me give you one more thing, whoever, okay. Okay, imagine if your proposed treatment didn't come out to be right. How would you make sure your treatment is going to be just right? Remember, the risk for treatment outcome. It's actually a risk for an aesthetic outcome. Okay. How would you make sure that at the end of the day, you're going to achieve satisfactory result? This is a lot of money. You can't screw up this case.
Direct composite mock-up, let her walk around with it for a few months.
Okay. How would you convince her to have orthodontics?
Show her the clean check, or if I'm taking a scan and just pretty much show her the video presentation, see what we can achieve.
Well, clean check will allow us move this teeth really fast. Assuming,
I mean,
Dr. Howard? And you take this, will allow us move this teeth fast. What was the shortest time you would do to move teeth?
3 months.
3 months. What would you note? What would be important thing for you to think when you're doing this 3 month movement? Who said 3 months? Christina, did you say that or someone else?
Yeah. Sorry, I was eating soup.
3 months, that's fine. 3 months, okay. What would you look for? Christina, don't answer this one.
I know.
What would you look for? Easy, this is for you. And you measure anybody else, please be on, you know, what would you look for in x-rays before you decide to orthodontics? I can see some voice of children, guys.
tried.
What would you do? What important exercise would you take as a part of the risk successful treatment outcome? You've done your pulp arterial testing, William. You've done your perio, you got your attachment. What is something very important you would want to know with this case?
I want to know the
Lateral
length of the roots.
Length of the roots. Okay, let's say they're pretty well optimal. Something else on it.
You just see the interdental bone, and if you need to do PAO, yeah.
Okay, it's fine.
Yeah.
No, it's a particular answer on it. Christina,
Position of the roots in the bone.
where? Which ones?
The lower laterals look concerning.
Right.
And also the upper centrals.
Mm-hmm. Right. And what would you say? What would trigger you in your treatment plan discussion with the patient? Because this is a highly informed patient with family that is high up in a dental, education. And they're going to be scrutinizing every word. Not because they can.
Dr. Sarkis,
Yeah.
are you hinting something along with the root angulation associated with the gingival, the recession, and also the exposure in ratio?
Gingival recession may be, but something else I want. Because you see, what I'm trying to make you all understand, thanks for that, Kath, is how everything's related.
What about,
yeah.
Sorry, what about with the lateral ceph? Just you've got to check the A and B angles, and the angulation of the roots can be assessed. Obviously, anterior angulations can be assessed that way, the A and B angles and so on.
I'll answer that differently. I'll tell you, William.
Yeah.
Let's assume you did all the average of the averages of your torque values, okay? Average
Okay.
averages. How does it impact on the facial aesthetics? How do you know? How do you know if you put your incised angulation this way, it's going to look better across the face? Do you know?
Well, from the picture, they have retroclined incisors, and there's a lack of lip support, proper lip support there.
Okay, fine, it's taken. But I need to take one measurement, so I know the end of the day,
VDA.
it's going to give me that insurance policy that I'm on the right track, and I won't be doing any gross damage. And if there was something there present, how else would I treat this case?
What about the vertical dimension of occlusion?
No. It's something very important. You're going to move tip. You're going to be convinced the patient to have orthodontic treatment. Isidoro, this is your
Are the roots within the roots within the bony structure? Take a CBCT. Are the roots within the mandibular structure? Or are they outside of the mandible? What are the positions of the roots?
I mean, mandible is such a big bloody thing. I mean, I want to be more better than that.
Okay.
What's the angulation?
Sarkis, Wade says root buccal plate thickness, buccal prominence of the roots on Wade. He says root buccal plate thickness, buccal prominence of the root of laterals 3-2 and 4-2.
Well, you're absolutely right. So what would you want to look at? You want to look at the lower cortical plate thickness. Is that clear? Because that is so important. You probably think I'm a prosthodontist. What the hell do I know about orthodontics? Let me tell you, I've done over 2,000 cases. And we use PAOO to reduce trauma to the bone to allow rep phenomenon for things to move. That's complicated. We'll discuss in my college. But the issue is, before you drool and jump into veneers, think conservative biology. Okay? You're probably wondering, how do we fix the problem? Okay. Any questions? Very good. I like all your answers. Kind of like your answer. Now, any questions before I proceed to the next slide? Yes, no?
No.
Okay. So the next slide is purely for a statement, because I think it's important that we understand, and this is what we teach at the college, is that there's a difference between looking and seeing. All right, I love this picture because, Vivek, are you there?
No, Dr. Sarkis, I don't think
No,
Vivek
he
is
took this
joined.
photo for me. And it's interesting how I'm thinking in terms of, this is the profile of the patient, okay? It's a profile of the patient. As I'm doing diagnostic mock-up, I believe, okay? Or I'm not quite sure, somewhere along the line. But nevertheless, I'm looking at a different angle in terms of how do I put the teeth in the right position within the facial frame. And this is what we teach at the college. In many ways, we do the diagnostic mock-up. We sit down, not a digital crappy smile design, we do diagnostic mock-up, because this is real time. What do you think signifies this picture to the patient? Can someone answer me? Okay, if you're the patient right there and I'm doing this, what would you think in terms of making your decisions as to proceed or not?
From the patient point of view,
Mm.
it's an artistic, well, it's something very much, I would think, artistically created and customized form of assessment.
That's right. It's a connection, isn't it? It's a connection with the
Yeah.
doctor, right? This is the ultimate connection with the doctor. You see, all this digital technology is going to not teach you that. Because you're dealing with human beings. You want to deal with digital technology and robots, go for it. But you are dealing with the human beings. Finally, people who want the best dentistry, okay, and they come to a stage in their life, they want to really look good for the next phase in their lives. They're not going to want just anybody to treat their teeth. They want someone who's got the knowledge, who's got the know-how, who knows how to ask the questions, who knows how to talk, who knows how to diagnose, you see. This is what I'm trying to explain to you. It's understanding how the mentor that puts you in a position you start thinking along the right way. Okay. And there are very few nowadays who really want to teach. They happen to sell the online courses, but the teaching is another thing. Okay. So this is the important part of the concept where people have that confidence in you, that they think you are the person who can actually take them to the next level. Because, that's not waste time. At her stage in her life, and you can see she's elegant, a very beautiful woman who wants to look good, okay? I mean, they want the right person to do the dentistry for them. And that's why they need a real smile design, okay? Because when you're doing a real smile design, and you turn the patient from here into here with diagnostic mock-up, I will have Lois. It allows a patient to think that, my God, if you can create this in the mouth in a matter of an hour and a half, 2 hours, then you can exactly where you're going to take them. So diagnostic mock-up is not digital smile design. This is a real smile design in a real time, okay? And it helps you as a clinician to connect with the patient. It's not about procedure, getting the handpiece and cutting people's teeth and giving the grief of their life. It's about being conservative. This is additive technology. We did nothing except put a couple little plastics here, add on what's required, because the patient's real in a real time frame. This is what we did for the patient. Now, the patient now understands how important it is to do orthodontics to put the teeth in the right position. And this was the deciding factor, the game changer, that she decided to go ahead and have orthodontic treatment. And naturally, straightforward, I want to know the end position. The end position of my treatment is very important. Do we need arch expansion? Absolutely. Absolutely. No question. Can you see how the lip actually forms so beautifully with my diagnostic mock-up? You're providing scaffolding. So you can't just think as a story dentist, put a couple of white bullets, little porcelain bullets. Oh, it's an IMAX bullet. I'm just putting an IMAX bullet, a couple of zirconia bullets. Let's shoot, baby. Let's shoot, see what happens. Okay, it doesn't work that way. You got to understand where you are going, and the most important driving equation is biology. So you can preserve biology. What I want someone to answer the question is, when you do the orthodontics, where you position the teeth so you have the right facial or dental labial or facial aesthetics. That's also very important, because you bring the tooth forward, then you cut the teeth back for veneers. We don't want to do that either, because you've got sensitive teeth. See, all the things that have to go into the treatment planning to put it all together. It's not just that simple, because if you want a recipe, I can't give you one. Whoever's going to give you one, your patient will look like monkeys, because there's no recipes. It's just going to look the same. But you individualize smile, you conserve biology, you help your patients to achieve the desired aesthetics, and that's what aesthetics is all about. So we put porcelain. I think this is a dentarium bracket. Okay, I don't need to go all the way down there. It's just straightforward. You put a couple of compasses, you open the bite, you build the teeth. Very straightforward. A lot of you have done this, I'm sure, and we improved. So the problem is, from here, William, remember? Okay, we did a diagnostic mock-up, which was here. That's a diagnostic mock-up. Okay.
Yes.
You see, yes?
Mm-hmm.
Any questions?
And it gives them a tangible image, you know, early on.
Exactly. Exactly. It's funny, you just see the whole scenario, okay? And then we put the teeth in the right position. I mean, you know, this is a whole couple hours of lecture for this patient. And that's, look at the similarities between teeth in the final, the top and bottom teeth are all restored with porcelain. And no injections, by the way, 0 injections, 0, okay? And went from here to there. Let's look at my diagnostic mock-up. Teeth are in a better position, we expand the arch. And we not only improve, we open the bite, and look at the whole smile line within the facial frame, lip frame, and that belongs to that patient. Am I making sense? If I'm wrong, please raise your hand, and I'm happy to answer it. Okay.
Yeah, from what I hear from a lot of players is that he's a good guy, and he just needs to, he can come back from it. But there's also a problem, you know, at Canberra. I mean, yeah, you've got a number of, you know, he come out today with this, and you know, he's pretty outspoken about the way in which he was at the club, and he'd been open and honest with the club. And
I didn't understand. I'm so sorry. Can you say that again, please? Sorry about this. Would you mind saying that again?
I think they were talking to someone else.
All right. Okay. Okay. Good. Okay. I didn't understand that. Okay. But what I'm saying is that you can see how diagnostic mock-up, okay, before orthodontic treatment is helping monostory outcome. Okay. And in many ways, we didn't change the arch much, so we improved the vertical dimension of the patient. And we knew exactly where to go for this patient. The treatment time took, how long did it take, Natasha, this treatment? About what? 5 months? 6 months?
Jan, I think, didn't we start end of last year?
Yeah. We started, so we finished
what these two guys have done.
Greg, I can hear you. Are you? Okay, now let's go next stage. Can you see the before? Can you see the difficulty we had? So if you bring this forward, you have to bring these bottom ones forward. When you open the bite, the chin goes back. So we have a number of issues we need to see. When you go back to this one, okay, when you come back, when you go back here, you can see that when we actually do the mock-up, it creates an anterior open bite. So it tells me how much I can open. It gives me how much room I can bring the centers forward. Am I making sense?
Yes.
When we go back here, that gives me exactly what I want to be. So you can't tell me you can do the digital smiles. It just doesn't work. You know how much time it takes to actually do it digitally? It's immense. Then you have to try it, forget it, it's too long. It works, but it's too long. So the issue is that from here to there, it takes good 6 months. We really hardly touch the teeth, only like slight, always intra-enamel preparations, minimal intra-enamel preparations. Good guardians, good lip control, improvement of the lip angle, improvement, the whole thing looks good. Okay, that's my opinion. Obviously, patient's happy. I shouldn't let them take the photos. But nevertheless, it's not really about us, is it? It's always about the patient, because patient feels really good about herself. And that's our job, to give the patients the confidence, okay, the expertise, okay, and to hold them during that important journey. It should take them from A to B. They will remember not just the work you did, but they remember that how important and how wonderful you made them feel during that process of journey. And that's what aesthetics is. Okay, it's a real mind game, okay? And it's about how do you create that effect. We talked about, you know, I see all the time on PDR, people posting their rubber dams, their opti-dam retractions, their veneers, their designs. I see it all the time. I want to see the face. You tell me that those teeth belong to this patient, which I think they do, and I'm happy. Because I know they belong, they're specially designed by me, replicated by my technician. Both Alice and Harry have done a wonderful job. They listen. My lab form, when I write this case, is like a page, summarized, all the images, everything's given.
Very political, so I mean, I wouldn't want to be the face of it at the moment. These players obviously showing support for the coach.
Okay.
And good on them. I mean, we're heading down that track, right, where every player, possibly fan, will need to be vaccinated to even play or enter the stadiums. I mean, that's where it's heading overseas.
Not sure who that is.
Where it looks like it's heading here.
That's what's happening in the NFL as well. So they're saying, and
Not sure who that is.
Yeah.
Someone needs
Can we
to
mute them?
mute Greg. Greg needs to be muted.
Can someone mute? Hang on. I can mute him. Let me see.
I've taken care of it.
Huh?
I've muted Greg.
Thank you. Thank you very much. Okay. So the issue is we create aesthetics by guiding patients through the important process, and patient is an important decision maker. Okay. And, you know, it was done mutually every step, and we make patients feel very special during that time. So the point I'm trying to make is when we think about diagnostic mock-up, okay, it's not just a lump of plastic that you put on patients. It's about, it's like when you did the first, you know, full denture setup, when you did all the little things you could do, it's combined to improve, to combine aesthetics, function, phonetics, speech is a very important part of the whole process. And when you look very carefully, you can see improvement in patients' dental facial profile, but we haven't opened the bite here. But when you think about, you know, the final look, where you sort of got a good lip support, and then you can see from here to the final stage, this is a larger picture naturally than this one. And you have the overall flow, creating flow. And, you know, we have more confident and a happy patient. That's what it's about. So I mean, talk about aesthetics and failed aesthetics. Well, this is aesthetics that we achieve, and it's all about customizing to your patients and their well-being and improving their confidence. So in many ways, when we look at those cases or patients, you can see that when you look at the oblique view of the patients, you can see the difference in how they see themselves, how confident they look, you know, going from A to B. And this is what we teach at the college. It's not just simply, you got to have midlines right, you be parallel to the interpupillar line, make sure your commissions are right. Doesn't mean anything. Aesthetics is not static, it's dynamic. It's a dynamic unity. Lombardi, back in 1971, wrote the most famous article. So it's a sins against visual perception and sins against aesthetic values. It's very interesting to note. And patients presenting in my clinic, and hopefully one day in your clinic when you do the program, will be able to appreciate your knowledge and your care. So my concluding remark today is tackle measures, plan for results, not for procedures. This is not a recipe. Don't promise perfection, but discuss the possibilities. Any questions?
How long the orthodontics was, Dr. Sarkis? For
3
few
months.
months?
3 months.
So you did the PAO for this one?
PAO.
PAO.
Special technique doing it, yes.
Mm-hmm.
I mean, this is not like, it's not one case. We do this quite often. But you get to know your patients. You know, like for me, you know, when we talk about aesthetics, right? For instance, like module 1 is photography. Now I will teach you photography. This is all my images. I didn't ask some professional guy to come and take these images because I can see from my eyes what I'm seeing. So I get the camera. I get the camera here, okay, and I shoot. That's what I do. So you have to see the guy who makes this work, who shoots these pictures, which happens to me in this case, or could be anybody else. But I take it and I shoot. But I'm going to tell you which angle to shoot. In other words, you know, people say, well, I want to know what you're thinking. Well, I don't know. What am I thinking? This is a starting point for this patient. What was I thinking? I was thinking exactly I'm going to be coming back to this stage. Okay, I knew exactly where I was going to go because that's the angle that's so important. People can't see this angle. That's the angle the observer can see. And that's the angle you're going to make it perfect because the top and bottom, you know, teeth are on the show. Where you place them is important. So when a patient says to me, I'm not happy with my work, or I'm happy where I've got. Now, I don't jump and say I can do better. No, maybe I can't. I'm not going to make that judgment call at all. What I want to know is what was done and what was the rationale behind the treatment. At the end of the day, we have not destroyed biology. At the end of the day, we maintain biology. See, I'm not a tooth cutter. I preserve biology. I also enhance facial aesthetics. And that's aesthetics. So when we talk about aesthetics, it's about conserving biology, improving the emotional factors. Okay, shared sensitivity, improved function. We covered up the sensitive dentin exposed. Okay, and more than you need to provide long-term function and long-term aesthetics. There's so many complex things. This lecture is like we have over 400 slides just on this case. We go one by one, the next stage, next slide, where you see how this is done. Most people say, I'll go from here to there. Of course, that's what I'm showing you. But I'm trying to give you reasoning in this short period of time. And we do this in our webinars, in Zoom sessions in between the modules, where you can really learn and ask questions. Because the most important thing is for me to challenge you as a student. Because unless you're challenged, you're not going to learn. If I chew and put in your mouth, I say swallow, you're not going to learn. If I challenge you, why would you do this? Then you learn, you become a fantastic clinician. I had a background having both trained in London and I was trained in Sydney. So you get to see the whole different views. And I've changed. I used to be so opinionated myself. But you learn not to be opinionated. You learn to sit back and learn and listen. And we teach you in the college how to listen to the patient. What's the important thing the patient is saying? So every day, for instance, I use my Samsung phone here. It's the best tool. I said, would you mind if I record you? Not a problem. Because I know recording is key to I want to see what the patient wanted in the first place. Very important. So we'll teach you a lot of interesting techniques on how to take a good image. I mean, would you, I'm not saying it's my image. Izzy, are you happy with this picture?
It's bloody good.
It's gorgeous,
Okay.
gorgeous.
Yes, natural.
He's looks a lot younger.
Okay, what I'm saying is that, okay, who would you want to teach you on photography? Me, or I'll bring some professional guy? Who you want?
You.
There's no doubt.
I'm seeing the end results back in here. Back in here. I knew I was going to be, because it's called, what's a knowledge? Knowledge is knowledge itself. What's a critical knowledge? Knowledge, experience, time, visibility, and that gives you critical knowledge. Okay, and I learn every day. I learn every day. I probably learn from my students than anyone else I can learn from. Okay, so you can understand how to do this to get that. That no one can teach you except in a program. Okay, so it's all about technique, but it's not really about technique, because that's easy to teach. But how to think, but how to create, how to compose, that's different. That is different. You're the mentor. Okay, I think Natasha wants to go to bed. Natasha, am I right, darling?
Dr. Sarkis,
Yes,
there
I'm
was a
very
question.
tired.
Huh?
There was one question, Dr. Sarkis, before you go, if the candidate is still there. They wanted to know, for the first molars, did you put the veneers or it's a full coverage crown?
It's a shell. It's a veneer. It just stops. It stops on the inside the lingual border. It's a millimeter long. It's a millimeter thick.
Good. Thank you.
Okay, if you ask me on the physical side of it, then that's a whole different story. You see, you'll be reading a lot in my course. You'll be sweating, but you'll be the best dentist in town. The knowledge you're going to get, you will actually learn how to get the knowledge. I'll guide you, but once you learn, you know what to do. See, you'll have your own ways of doing things. That's just as good. See, my idea is to develop your hands and your creativity, improve the neuroplasticity in terms of creating your own flair in your treatment plans. Because I'm sure there's another colleague doing the same thing at different ways. So, see, there's many ways to achieve the same result. I just did one way. But for me, that one way is the best way, because what determines the outcome is conservation of biology. Am I making clear?
Yes. Just one other question.
Mm-hmm.
Would you always recommend splint coverage for nightwear after occlusal rehabilitation like that?
Okay. Look, the answer is yes. But your occlusion of prescription is important in determining a lot of things. So the occlusion prescription for this patient is very complex, and but that's the end point. You'd be surprised when we do the treatment how it works. You know, we did the upper arch and we reassessed, and then we went back to lower arch. Lower arch. Can you do both arches at the same time? The answer is no. One arch at a time. There's a reason for that.
Yeah.
There's no need to be gung ho. Just take your time, reassess, think, make changes, let the patient adapt, and you know, check lots of things, lots of factors, and you go next stage. I mean, she's a beautiful woman. You know, she's a refined woman. Can you imagine putting her through a nightmare of unnecessary tooth intervention, unnecessary, you know, when you can restore this and make her look absolutely stunning, just improve the, what you're doing, you're complementing her beautiful aesthetics, okay? And in terms of doing conservative dentistry. I mean, you think about it, you know, and if we did give a local, and I usually do them, there's a special techniques I can teach you. You know, we don't give labial, so we give you palatal injections. I do a special techniques where you can make the whole mouth now. So it's not, you're not going to learn about prosthodontics, you're going to learn about clinical techniques. You're going to see clinical how to do this, which way to do it, what's another way to do it. So it's like you'll be bombarded with knowledge. So you can't read this, you can't get this from anywhere. You got to get it from my head. That's what it is.
Yeah. Thank you.
Thank you all. Thank you, Natasha, all my colleagues. Thank you all for being with us. I'm forever grateful that you took your time to come in and share all these interesting ideas. And again, those who want to learn, you know what to do, and you can talk to Natasha or Strada.
Thank you so much, Dr. Sarkis. Each one of the candidates would be receiving a thank you email after tomorrow's webinar. Please touch base with us if there's any questions regarding the course. We're more than happy to help. Thank you.
Thank you, Dr. Sarkis. Thank you, everyone.
Thank you, Dr. Sarkis.
Thank you.
Bye. Thank you.
Thank you.
Thank you all. Thanks for being with us.
Bye-bye. Thank you.
Bye.
Thank you.
Bye-bye.